there were a few things that I normally teach in that second unit that I want to make sure are covered. And what I just did is I just printed you, since there weren't that many slides, that I just pulled some slides over from my old notes and put them here. So that I just went ahead and printed it for you. So you've got a copy of it. And I tried to put up at the top, I looked in the new book. Now, if you've got last year's book, it may not be the same page number, so you may have to look. But I tried to put the page number that corresponded with these things, because a couple of these were in the last unit in your book. So, does that make sense? Okay. So, the first thing that I just want to make sure that we all understand is that RH alloimmunization. And that was what we put up on the board, right? Does everybody understand the names and stuff? I erased it on the board, but hopefully you got a picture of it, just to make sure that everybody understands that, remember, it's not the first baby that is the problem, or that has problems. It's the second baby that has problems, right? Does everybody understand that? Okay. So the picture that I am passing around, that I passed around, I think is a really interesting picture, because it shows what happens as the mother is exposed to that Rh negative blood, or that Rh positive blood when she's negative. Okay. Another thing I want you to remember too is that the reverse does not occur. So if a woman is a positive blood type, she is not going to get RhoGAM during labor, even if the baby ends up to be negative. Okay? Because for some reason, do not ask me to explain, but for some reason, that sensitization does not occur when the mother is positive. It only happens when she is a negative blood type. Okay? So, only women who are negative blood types get RhoGAM. When do they get them? Do you remember? 28 weeks. And then when's the next one? Within 72 hours after birth. Right, 72 hours after birth. Okay? And again, that RhoGAM is given to trick the body into not producing antibodies, that active immunity against the other blood type. So it's a trickster. It's tricking it, the thinking that it's okay. And I've got on your slide the biggest concerns. We talked about the fact that the baby will bleed out, and what that's called is the severe hemolytic syndrome. That's the fancy word for it. Or erythroblastosis fetalis, which is another fancy word for it. So it'll cause fetal edema, it'll cause them to bleed out, become anemic, but it's not the first baby. It would happen with the second baby. Does everybody understand that? And on your picture, it says, I don't have it in front of me, it can occur with previous pregnancy, miscarriage, or with bleeding during the pregnancy. So you see, it may be, and I think that's one of the scariest things about Rh alloimmunization is that you may not realize that you were pregnant. You may have had a miscarriage and not even realize that you were pregnant, and you already built up those antibodies. So, you need to make sure that women understand those signs and symptoms of pregnancy, how to recognize it, and to get prenatal care as soon as possible. To start visiting that physician as soon as possible. Okay, so does anybody have any questions about that? Yes,
say you have a patient that says that they have an abortion at 6 to 8 weeks. Is the likelihood that they've already built up those antibodies pretty high? Yeah. So would you? And you said that you can't give them RhoGAM at that point.
Right. So you have to keep a close eye on. And there's a chance that they may have a baby that's fine. a very small chance if you want to make sure it's just like blood.
I know why it affects baby. The water makes the antibodies do that.
Positive blood type, alternate.
And then once it has seconds, kind of like an infection, these antibodies go and attack the baby.
Right.
But the baby doesn't normally. They're sharing blood. They're sharing stuff with the baby,
Right.
not the baby sharing stuff with them. So that's why it doesn't affect the baby.
Right, right, yeah, that's why it doesn't affect the baby. Right. Exactly, so again, it's that second baby that's in danger.
That's
Being unlimited.
yeah. That's not happening.
Right, so, yeah, and they have another baby. Okay, so again, really the moral point of this story, right, is to make sure that if you are a negative blood type, you're broken, period. It's not going to hurt you if you have a negative baby. It's not going to make any difference, but it is going to make a difference either way. So if you know you're a negative blood type, that's just a given. You just automatically do it. That's the point of this whole story, right? And to tell everybody that. Okay. Okay, so the next thing I want to make sure that everybody understands is STDs and torch infections, because y'all didn't talk about torch, right? Okay, torch is actually very, very important. And it's this stuff is on page 342, so it's actually in your antepartum section, because they ask these questions that relate to STDs and torch in that first prenatal visit when they're asking all those questions about, you know, your well water, do you have well water versus city water? Do you have, how many people do you have living in the house? Well, I mean, all those questions. It takes about 2 hours, that first interview. And one of the questions that they're going to ask you is, have you ever been exposed to an STD? Now, the mnemonic torch stands for the things that are listed there. Toxoplasmosis, other infections, which is not a very nice little thing, but it's just kind of random, rubella, cytomegalovirus, and herpes. And all those things are potential risks to that growing fetus. So I just want to briefly just mention each one of those. Toxoplasmosis, what do they ask you? What is one of the things that they would ask you?
Cat.
If you have a cat, if you have a pet, specifically if you have a cat, because litter boxes can grow toxoplasmosis. Now, they're not going to tell you that you have to get rid of your cat, right? But they are going to tell you that you cannot have any contact with that litter box, which, you know, for those of you who have a cat is a nice thing, right? So somebody else has to change the litter box. But that is something that they say absolutely not. You can also get toxoplasmosis from eating raw or undercooked meat. Raw or undercooked meat. So those are the two things. It can be treated if you catch it early. Okay. Sulfa medication, sulfalazine is one of the drugs, the sulfur drugs. If it is left untreated, if you are exposed to this toxoplasmosis and it is not treated quickly or properly, it can cause fetal death and disease. Okay. All right, so everybody understand litter boxes bad and raw or undercooked meat bad. Okay. The other infections include this kind of a rainbow or a umbrella for other infections that can hinder the pregnancy. Those are included with groupie strep, urinary tract infections can affect the pregnancy, and vaginal infections. So all three of those things are very toxic to the health of the pregnancy. Group B strep, urinary tract infections, and vaginal infections. I really want to put a plug out for Group B strep. I don't know that did Ms. Walker talk about Group B strep at all? A little bit?
Yes.
Yeah, the Group B strep. It's very, very, very bad. And a lot of women are Group B strep positive. Group B strep is not an STD. Let's all remember that. It's just that you've been exposed to that strep strain. I was Group B strep positive. And if you treat the mother during labor with a penicillin, the baby's going to be fine. Okay? So they have to be treated for Group B strep. Okay?
Is that where you don't want her to deliver for 4 hours after you give the antibiotic?
So what?
Is that, didn't she say something about not delivering or having the antibiotic in your system? Is it 4 hours?
You would like to have it 4 hours if
Okay.
you can. Now, people who have to have an emergency C-section, stuff like that, you can't. But you definitely, and if that's the case, then they end up getting more than one dose of the penicillin. I did see a baby about 4 years ago that had in PICU that the mother had not been treated properly for Group B strep, and the baby ended up dying. It took a week, but the baby was several weeks old. And it was a very horrible, horrible, horrible situation. And developed Group B strep meningitis, and it was very bad. So it is something that has to be treated. It cannot not be treated. It has to be treated, and it's something that you need to make sure that people get tested for. Again, it's not an STD, so there's no stigma attached to it, but they've got it. It's just something that people have been exposed for. We're going to talk about cytomegalovirus in just a minute, and that's something a lot of people are exposed to and never know they have been.
So with my mom, she was tested positive earlier in pregnancy, and I see her then, but then she was positive again, they do her third and
Yes.
like portion.
Yes, just to be on the safe side. It's a big deal. It's a big deal. Big deal.
When my daughter was born, I didn't get 4 hours of antibiotics because it was 2 hours between.
Yeah, I didn't either.
But
And
they
you see
would
people
not
use all the same.
release her from the hospital, and they said the reason was because she didn't get 4 hours of antibiotics, but they never explained what it was they were even looking for.
To make sure that she didn't develop any signs of infection, meningitis.
But if it can take weeks to show up,
It doesn't have to take weeks. This baby, it just took weeks.
but I mean, so
So that
what
you're-
was the? I mean, they kept her for an extra 24 hours.
to make sure she didn't start running fever,
Right.
having
But
feeding problems.
why could I not go home and monitor her for signs
Because
of
they
fever?
get safety. I mean, being in hospital. I would rather be in the hospital to make sure just in case something happens. So, but it is very serious, and it's something that everybody needs to make sure that they are aware of. Rubella, we're giving MMRs now. Is anybody giving an MMR in labor? Rubella is something that they're finding a lot of people who, even when we got it when we were children, we are not retaining the immunity for it. You got to get it for here, yeah. I mean, it's something you hope that you retain immunity, but you might not. Yeah. So rubella is the German measles. That's the slang term for it, the German measles. If you are not treated with a rubella vaccine, a baby can. The mom is tested for immunity, and bless you, and vaccinated only if pregnant. So the baby has to be born in order for her to get the vaccine. Does that make sense? She gets it after birth. The mom gets the vaccine after birth. Because they do not want her to pick it up and expose her newborn. It can cause congenital eye, ear, and heart defects if a newborn is exposed to rubella. Congenital eye, ear, and heart defects. There have been some instances where the baby was mentally retarded. CP, cerebral palsy, from they suspect from germ immunity. So again, they're going to be testing you for all of this stuff in that antepartum period to make sure that you have immunity or don't have immunity and what they're going to do for it. All right, the C is cytomegalovirus. Over half of all adults, so half of you in this room, have been exposed to cytomegalovirus at some point and have immunity to it. I have immunity to it. So at some point at the hospital, and that's something else. I really want to make sure that everybody understands how important it is for us as healthcare workers, if you get pregnant, just to go ahead and get tested for all this stuff, because you don't know what you've been exposed to, right? I mean, I've got tested for everything. Because I've had G-tubes explode in my face. I've had blood all over my hands. You don't know what you've been exposed to. So it's just best just to go ahead and be tested. The cytomegalovirus, again, half of you in this room have an immunity to it already, have antibodies to it. If you have an active case of cytomegalovirus, an active case of it, it's in the similar family to mono. It's in that similar strain of mono, like the Epstein-Barr virus. It's in that same family. It can be fatal to the fetus. % of babies who do survive with a mom with an active case develop severe neurological problems. Severe neurological problems. Eye abnormalities. And hearing loss. So again, very, very important to be tested for, just to make sure. It's a virus. There's no antibiotic that's going to treat it, but they will at least be aware if you already have the antibodies for it. And then the last one is herpes. You all should know about herpes. The primary infection is the greatest risk to the baby because it can cause spontaneous abortion. If a mother has active genital herpes, do they allow her to vaginally deliver?
No.
No. Right? They only will do a C-section. The transfer of herpes from mother to fetus only occurs after the rupture of membranes. So that transmission only occurs after the rupture of membranes. So what they do is they will treat that infant after delivery with IV acyclovir. They'll go ahead and treat the baby for IV acyclovir. ACYCLOVIR. The treatment for herpes. However, it is not found in breast milk. Herpes is not found in breast milk. So mothers who have herpes can breastfeed. Okay. There are a lot of STDs. I mean, they're going to test for all the STDs. Chlamydia is the most prevalent STD. Of course, it can be treated. Y'all learned that with Ms. Atkinson, right?
Mm-hmm.
Do you remember what the treatment is for chlamydia? Penicillin, doxycycline. Yeah, you can't take penicillin. Okay, let's talk about, speaking of STDs, let's talk about HIV and AIDS, because y'all didn't talk about these mothers either, right? Okay, this is found on page 309. Again, it's in the antepartum section of your book. There, what I've got on your slide are the maternal risks and the fetal risks for mothers who are HIV positive. Now, The problem really is for mothers who are non-compliant with their antiretroviral therapy. That's what causes a lot of these problems for the fetus and during pregnancy. So it's for mothers who are non-compliant with their antiretroviral therapy. What are some of the things that HIV causes? What are some of the problems that, remember that wasting syndrome? Okay, how would that affect pregnancy? How would wasting syndrome be a problem?
Baby won't get the metabolic needs.
Okay, the baby might not get their metabolic needs to grow and develop. What about yeast infections? That's common with women with HIV. There's a lot of those issues that can cause difficulty to the pregnancy and for the fetus. Now, pregnancy is not believed to progress HIV, which is a good thing. It's not believed to progress HIV. And as long as the mother, the HIV mother, takes her antiretroviral therapy consistently during pregnancy, as long as she takes her antiretroviral therapy consistently during pregnancy, there is a very low chance, around 2%, that it will be transmitted to the fetus, which is very good. So not all babies born to HIV mothers are going to develop HIV. Now, intrapartum and postpartum hemorrhage, or wound healing and infections. Those are common things for the mother. I do want you to look under the fetal risk. The virus does cross the placenta. The virus does cross the placenta. So that's why they want these mothers to be very strict with their antiretroviral therapy, especially, and y'all talked about that with Miss Beaver already, right? Or somebody, y'all talked about HIV?
Mm-hmm.
Yes. Or is that this summer? Okay. There is a big, long medication called ZDV. Have you heard of that? It's like Zydovulvine or something. I always just call it ZDV. Okay, ZDV. And that is part of that antiretroviral therapy medication. Okay. ZDV is what is thought to prevent that transmission from mother to fetus, as long as they consistently take that drug. Okay, so that's part of the antiretroviral therapy, that ARV. So ZDV. Z is in zebra. DV. I'm not going to put the full name on there, just ZDV. Okay. Okay. So if it crosses the placenta and it's found in secretions, are they going to encourage them to vaginally deliver, you think? No. They're going to want them to have a C-section. They also do not recommend any kind of invasive procedure such as an amniocentesis because the risk of transmission is high. And they do not encourage them to breastfeed. This is the one time that you do not want the mother to breastfeed, is if they're HIV positive. Okay. So, of course, prenatal testing is important. They want to make sure that there's no other infections that are present along with the HIV. So they're going to do a lot of testing. This is one of the most important parts of the slide. No matter what their CD4 count is, and that is the CD4 count you learned with Ms. Beaver, is how they determine the level of your HIV, where if it's progressing to AIDS. So that CD4 count. no matter what it is, even if they are asymptomatic and it is a low CD4 count, they are still going to do this 3-part antiretroviral therapy during pregnancy, during labor and birth, and postpartum. Okay? So no matter if they're asymptomatic or if they have early HIV, they are still going to have them do this, because remember, if they are consistent with their medication, the chance of it transmitting to the fetus are very low. So, antepartum before labor, they are going to take oral ZBV daily. That's the first part. Oral ZBV daily. During labor and birth, they will give it to them IV. They will have IV ZBV. A lot of B's. IV ZBV. And then postpartum, not only will the mother go back to taking it orally, but they will give it to the baby for 6 weeks following birth, because they cannot test for those antibodies until after the baby is 6 weeks old. So in the meantime, we want to make sure that they're treated in case they need it. Sure. Yeah. Okay, so the postpartum part, let me start with you. So antepartum, they need oral ZBV therapy. During labor and delivery, they get it IV ZBV. And then postpartum, the mother takes it orally again. She goes back to oral. And the baby will also get oral ZBV for 6 weeks.
They give it like in a liquid or something.
And then they'll test them. They'll test them to see if there's antibodies present, because that's how long it takes for those antibodies to form. And then if they have it, yay, we've already started treatment. And then they'll quit it if they don't. 6 weeks is the length. Okay. They also, no matter if they're asymptomatic, are going to do weekly non-stress tests starting at 32 weeks, because they want to make sure that the condition of the baby is okay, that the baby is growing and developing, because remember, with HIV, you have that wasting syndrome, you have infections, they're prone to infections, so you want to make sure that the baby is growing and developing like it should. So no matter if they're asymptomatic, no matter if it's an early case of HIV, they will start doing weekly non-stress testing at 32 weeks. Okay. If they suspect anything, of course, they're going to do an ultrasound to check for growth restriction, and then I've already said no invasive procedures. Okay. All right, so far. All right. The last thing we're going to talk about, which is for several slides, because it's very important that you understand gestational diabetes and women who are diabetic or pre-diabetic or diabetic before they've got pregnant. Pre-pregnancy diabetes. Okay, so everybody really needs to pay attention with this one. And you know, one reason this is so important, it's not like I'm going to have 25 questions on the test on this, it's just that with our diabetic population today increasing, the chances of you coming in contact with either a mother who was diabetic before pregnancy or who develops gestational diabetes is pretty high. So I want to make sure everybody understands this. This is early in the antepartum section of your book too. So this is on page 294 in that new book. Okay? All right, so does everybody understand the term gestational diabetes? What is gestational diabetes?
First year in pregnancy.
Okay, so they have occurred when you become pregnant. The changes have occurred. What do you think, what are risk factors for gestational diabetes? Obesity, large babies. Now, you wouldn't be gestationally diabetic, you would be diabetic, period, right? Okay. But what if you have a family member who is diabetic, a strong familial history of diabetes, or a family member who was gestationally diabetic themselves? Okay, that increases your risk.
I have like the increased risk for infection, like
It will. We'll talk about that in just a minute. Yeah, and we'll talk about that in a second too. The things that cause people to develop gestational diabetes: obesity, strong familial history, and a prior history of gestational diabetes. Okay? Now, some things I want everybody to remember when we're talking about this is that glucose levels in the fetus, okay, think about this, glucose levels in the fetus are directly proportional to the mother's glucose. So if she is uncontrolled or has high blood sugar, the baby's blood sugar is also going to be high, right? So glucose levels are directly proportionate from the mother to the baby. Here's the kicker, that glucose crosses the placenta, that's why the levels are the same, but insulin does not cross the placenta. Okay? That's a problem. Insulin does not cross the placenta. Now, at 10 weeks, fetal insulin production begins.
What? How many weeks?
10 weeks.
10.
Fetal insulin production begins itself. Okay? But in the meantime, that glucose level has to be maintained, because if it is high, it's going to cause the babies to be high, and we're going to have other issues we'll talk about in a second. Okay. Now, you all talked about diabetes already, so you should understand the pathophysiology of type 1 and type 2. Everybody understands that. Okay. A woman who is diabetic who becomes pregnant, okay, we'll say she's diabetic, she becomes pregnant, not nurses. They recommend that these women maintain a blood sugar of 95 or less fasting, 95 or less fasting, 100 before meals, and 2 hours post meal, it should only be around 120. That is a very tight range. Very tight range. Okay, so there's not a lot of wiggle room there. So 95 fasting, 100 before meals, and no more than 120 2 hours after a meal.
they want them to do this their entire pregnancy.
Their entire pregnancy. Their entire pregnancy. So you see how tight that control is.
So after 2 weeks, the baby gets some blood behind it. So does that help
It
regulate
helps.
the
It
baby?
does help. It does help. But still, if you've got really large cells. All right. Now, let's look at the difference in these mothers' first, second, third trimester. Okay. First trimester, what's occurring? What's the baby doing in the first trimester? Developing. He's growing, he's developing, he's changing. So the mother's metabolism is increased. She needs a lot, she's using a lot of energy, i.e. in parentheses, glucose, to grow and develop that baby. Okay? So, do you think that she would be prone to hypoglycemia in the first trimester or hyperglycemia? Hypo, because she is using so much energy and so much glucose to maintain that pregnancy and to grow that baby. So, what do you think that their physician's going to do? They're going to decrease their insulin need, right? So, the insulin need in the first trimester for a diabetic patient is decreased. Make sense? Because she's using all that glucose to grow that baby.
When this is if they've already have diabetes, or
Yes, this is even gestational diabetics, they still follow the same train. Okay. In the second trimester, however, the second and third trimester, the baby's already growing and developing. Okay, the baby's already growing and developing. Glucose use and glucose storage by the mother and the fetus increase. Okay, so if the mother and the baby are hanging on to more glucose, they're not burning it up like they were in the first trimester. They're keeping it more. Glucose use is increased. Okay, because they don't need it like they did in that first trimester because the baby's already grown. The baby's already developed. All the organs are developed and all that stuff. So even though the baby is still growing, it's not at that rapid pace as it was in that first trimester. Everybody with me? So that glucose that the baby's producing and the glucose that the mama has is stored, so we're hanging on to it. So the insulin requirements during the second and third trimester are what? Increased. So whereas the doctor may have changed and dropped the insulin in the first trimester, now the insulin requirements may double up to quadruple. Okay? So what would she be at risk for in the second and third trimester? Hyperglycemia and as high or as much as DKA, diabetic ketoacidosis, she's at risk for DKA. With levels as low, what we consider as low as 200, they can start building symptoms of DKA. Because remember, what did they want that blood sugar to be maintained at? 95 to 120, right? That's our range. So it doesn't take much to throw that mother into DKA. All right. Now, the baby is born, okay? The placenta is born. The cord is cut. What do you think happens now to that blood sugar? It drops at the bottom for both mama and baby. So after labor and birth of the mother and the placenta, after labor and birth for the mother and the baby, the cord is cut. They are both now at risk for hypoglycemia again. It will drop, but maybe not as dramatically, because he keeps getting out. Okay. Now, almost all women who have pre-gestational diabetes, this is the women who were diabetic before they got pregnant, become insulin dependent during pregnancy, even if they were on oral hypoglycemics. Yeah, type 2s. They will become insulin dependent during pregnancy. There is a lot of research out there right now that is saying that they may see that it's okay. There's some safety issues. Let me back up. Let me get this out. The reason that they never gave oral hypoglycemics is because there was safety issues. They felt that it was toxic to the baby. There is research now that's showing that metformin may be safe to give, but not a lot of doctors have gotten on board with that. Most of them are still doing the insulin, even for type 2 women who were on oral before. Okay, does that make sense?
I was just gonna say, this is like tying my mother and baby experience together, because my mom was gestational diabetic, and the baby's blood sugars kept running in the 30s.
Yeah. Drop it down.
Nobody explained it to me.
That's why, because the baby didn't have that oral glucose, or that glucose circulating anymore, the mom's glucose. So it was like they took all the sugar away. So, yeah. That's why.
will the baby be more colicky or cranky, kind of coming off of that, basically?
Not really. They're sleepy, they're jittery, they almost look like they have little seizures because they're like it's almost like the caffeine withdrawal. They're without that sugar.
They were encouraging her to formula too.
Because you got to get that sugar. A lot of those babies who their blood sugar keeps dropping down, and you can't get it up, you end up getting a glucose water because you've got to get the glucose up. I've seen babies on glucose drips, dextrose drips, trying to get the glucose up because they have a hard time getting it up. Okay, so let's get going.
So does that make the baby more likely to have diabetes whenever they're older?
Good question. No, but it does make the mother who was gestationally diabetic more at risk for developing type 2 diabetes later on in life. Not the baby, but it does the mother. Okay?
So not necessarily related to gestational diabetes, but checking blood sugars for the baby. The mother that I had when I was on OB, she delivered at like 36 weeks because she had a previous problem where the baby had died in utero late in the pregnancy. So they did a C-section. She was not did not have gestational diabetes, but they were checking the baby's blood sugars for the first 24 hours.
It may have been due to some other condition.
Okay. Because I was looking through the chart and I was like, I didn't really understand.
A lot of conditions.
My baby that I saw was at 36 weeks too, and he was like 9 pounds. So they said they were just checking blood sugars
Because he was so big. Yeah. Because it's like a 9-pounder or yeah.
And she was like right at a little, not quite 6 pounds.
So
So yeah, she was tiny. So I
there's
didn't know.
probably something else going on. Okay. There are some positions too, I'll tell you this, and it makes sense if you think about it, that we're actually trying to get, speaking of babies' blood sugars that are in the 30s, they're really low, and you just can't get them up no matter how much you feed them, no matter how much glucose water you give them. There are some physicians out there who will actually give them a dose of steroids. Because what does steroids do? What's the side effect of steroids? Reduce your blood sugar. So there are some physicians out there that will do that. A couple of doses of steroids to see if that'll increase it. Glycogen, all those kind of things. You just have to be careful with how you give it. Okay, so let's talk about the maternal risks for women who are diabetic. PIH, pregnancy-induced hypertension, which should make sense because diabetics have a high risk for hypertension, right? Because what happens, that glucose coats the vessels, right? Just like cholesterol, coats the vessels, it hardens, so it causes PIH. So then you have the complications of PIH with these fetuses. They're not growing, they're not developing, they're not getting nutrients and oxygen that they need. So PIH is definitely one. They are at higher risk for hydramnios, which is what? Remember?
Too much
Too
fluid.
much fluid, leading to a premature rupture of membranes. Because too much fluid will cause premature rupture of membranes. And that, of course, by itself is dangerous. Infections, such as urinary tract infections, very common in women who are diabetic because glucose acts as a growth medium for bacteria. So very, very important to teach them proper hygiene, wiping, signs and symptoms of a urinary tract infection, keeping a close eye on that. we already talked about DKA. And worsening of retinopathy. So diabetics who become pregnant are automatically referred to an ophthalmologist to make sure that they keep a close eye on their eyes. Even if they don't have retinopathy already, it makes it, the chances of it increases, it makes it worse, so they're going to keep an eye on them and follow them really close. Okay. Now, fetal problems. Sudden unexplained stillbirth, especially with women who have uncontrolled blood sugars. Okay, so poor control. Congenital anomalies. They are increased 6 to 12%. Over the diabetic population, pregnant diabetic population. This is one that everybody thinks of as macrosomia or large for gestational age babies. That's a common thing. However, it actually, you could consider it a myth because not every diabetic is going to have a large for gestational age baby. They may be larger than normal, but they're not huge. Now, I've seen some sumo wrestler babies who their little eyes can't even open because they're so huge. But those women have very poor control. You can, especially if the mother has a coexisting condition like PIH, have a very small baby because they didn't get enough nutrients to grow. And intrauterine growth restriction, that kind of goes along with that because of lack of oxygen. And then, of course, neonatal hypoglycemia, like we were just talking about. All right, so let's talk about what they do with these people because they watch them very closely, very, very, very closely. Okay? Women who are at risk of gestational diabetes, women who are at risk of gestational diabetes, so those people who have a history, a family history, who are overweight, all those conditions, they are going to do testing. Those of you who have been pregnant probably had that wonderful oral glucose load. It depends on the condition and it depends on the laboratory whether or not they do a 1-hour test or a 2-hour test. But you go into the lab, you drink a nasty Tang flavored drink. And you have to drink it quick, and then you sit in the waiting room and read your book or do whatever, and then they will come back in either an hour or 2 hours, depending on your physician, and they will check your blood sugar. They'll do a blood draw to see how did your body handle that quick burst of glucose. Was it able to be absorbed? Do we have enough insulin to break it down? If the number comes back greater than 140, then they prescribe a 3-hour glucose tolerance test. And then what they do is they increase the amount they've been giving you. So that they were giving you 50 grams of a glucose before. Now they're giving you 100 grams, and they're going to check your blood glucose over every hour for 3 hours. If at the end of that you are still elevated at the end of those 3 hours, then most physicians consider that point to be gestationally diabetic and they will follow you closely. Now, they may not start immediately with insulin. They may try to send you to a nutritionist and work on what your eating habits and all that stuff. But some women who have a very high blood sugar, they will automatically at that point go on insulin. These pregnant diabetic women have frequent visits at the doctor, usually every week to 2 weeks. So they're there all the time because they're wanting to keep a very close eye on that baby, making sure that there's no problem seen. Of course, they have to have an increase in calorie. During the first trimester, they recommend an increase of 30 calories per kilogram of weight. Increase of 30 kilocalories per kilogram. And then during the second and third trimester, an increase of 35 calories per kilogram. And the nutritionist will recommend that they do 3 meals and 3 snacks, with the most important snack being the bedtime snack. And they want to make sure that the bedtime snack includes protein and some complex carbohydrates. So a good sandwich, because what's going to happen is that during the night their blood sugar is going to drop. So they want to make sure that they want to maintain. Okay, we've already talked about insulin adjustments. So the first trimester they may have a decrease in the amount of insulin they're getting. And in the second and third trimester they may have increase. Urine testing for the onset of DKA, they're looking for ketones. Close monitoring of any exercise, and of course monitoring the fetus. They will do an ultrasound to make sure that there's no congenital anomalies. They will do a non-stress test at 28 weeks. And then starting at 32 weeks, they will do twice weekly non-stress testing. That's a lot of time in the hospital or office. So non-stress test at 28 weeks, and then twice weekly starting at 32 weeks, just because of all of the risks. All right, now a quick little note about labor. Depending on how much energy the woman uses and produces during labor, will determine whether or not she has to have an insulin drip during labor. Okay, if she is producing a lot of glucose due to the stress response of labor, then they will start an insulin drip. Typically what they do, and I don't know if you know this or not, but typically what they will do is they start 2 lines on these women. They'll start a D5 line, a dextrose line, to make sure that she's getting enough glucose. And then they start another line with saline. Did you know that insulin sticks to plastic? Anybody ever told you that? Insulin sticks to plastic. So it sticks to IV lines, it sticks to the bags that the insulin is in. So if you have a mother who has to go on an insulin drip, and this is actually for any diabetic, if you have to start an insulin drip, this is just one of those things that you gotta know. You have to coat the line with insulin. You just have to inject insulin into the line to coat the line so that the insulin in the bag will go straight through.
So you still prime your line just with the insulin.
It just sticks to tubing. I guess it's a type of plastic that sticks to tubing. Okay? They're going to do finger stick blood glucoses hourly on these women. Every hour they're going to do a blood sugar check, because for one thing, you may need to stop that D5 because the blood sugar is going up, and then you have to start the insulin drip, or you may need to stop the insulin drip and start the D5. It's a constant. It's a constant up and down, depending on how much energy they're producing and using. And every person is different. Everybody's different. Okay? And then once the placenta is born and the cord is cut, they're automatically going to stop that insulin drip if they started it, because of course we're at risk now for hypoglycemia, right? So we don't want to have it drop out too much. Alright, so looking back over what we have talked about in the past 60 days, what questions do you have? Is there anything just burning in your soul?
Test is Monday.
Test is Monday. That's why I wanted to ask this, because I'm technically done. So you can technically go home, but I want to make sure that nobody has any questions for me before you get out of here. No, I looked at it this morning, I have one math problem. Today is the day the BSN people, and they're going to be here at 11. Thank you for mentioning that. Yes, they're going to be here at 11. UNCG and Tava are going to be here. I don't know who can afford college. No hands and good luck. But they will be here, and they're going to be in the big lab. Okay? What I did was the stuff, everybody listen, the stuff that I did today, the stuff that I talked about, the extra stuff today, I added 5 questions on the test from the stuff that I talked about today. Okay? So your test is going to be 55 questions. It was looking through my 50 questions, it was hard to decide what I didn't like, so I decided I added extra.
We'll take it.
Right, just another matching. Remember the test, and that's what stresses everybody out the most, and I don't have a whole lot of questions on those tests. So I want you to know, if you have a woman that's 10 weeks, this is the test that you would do. Or if you have a woman who comes in and says that she smoked the entire way during pregnancy, well, you know that you need to do a doctor's blood culture. Does that make sense? Look at those things. Right, everything we did yesterday. Now, all of that ultrasound stuff, don't worry about, okay? Because an ultrasound is an ultrasound is an ultrasound. It can tell you a lot of different things, right? But I'm not going to get all of an arms on that.
So I'll still have the protocol, but not all the
Right. Right. Stuff y'all put pictures of.
the only.
Okay?
What did she decide?
Does everybody feel pretty good about it? Kind of maybe quickly. I looked at it and I thought it looked real easy.
We need it.
Yeah, I'll let y'all.